Welcome to the Canadian Foundation for Healthcare Improvement's Quality Improvement Primer Series. These primers are designed to provide healthcare leaders with an introduction to concepts essential in leading successful quality improvement. We hope these primers will be useful to inform your improvement journey. Enjoy.
Hello there, this is Jim Handyside. I'm with Improvision Healthcare. I'm really pleased to be joining you today on this primer on driver diagrams. What we're going to do is take a very short time to become familiar with what a driver diagram is, to recognize the input that you need to develop your improvement theory, which is your driver diagram, and to differentiate the driver diagram from some other improvement and planning tools. Let's start with a personal improvement. No matter what kind of improvement you're going to be making, you'll have some sort of idea that you want to make some change. And that change is actually a theory. It's sometimes articulated and sometimes not. And what we want to be careful of is that we don't have some sort of black box. We want to get the theory out in the open and be able to see what the theory is, share the theory, learn from the theory, adjust the theory as time goes along. So if I have a personal improvement to improve my health and well-being, let's just start at that level. And let's say that I come up with, I want to improve my physical health and improve my mental health, and decide for argument's sake that I'm going to focus on my better physical health. And when I begin to think about that, I realize at this point in the Canadian winter, I've gained some weight. I want to reduce some weight. And so I realized that to reduce weight, really there's two things you can do. You can consume less or burn more. Reducing weight is really sort of a mathematical equation. It's based on physiology, so we'll start there. In order to burn more or consume less, I would ask myself, which one of these would I think would be better? I might consult some evidence. I might look at weight loss and personal improvement research. It turns out that burning more is actually a better choice. A better choice for me and a better choice by the research. So I'm deciding that there's two things I can do. One is to change my daily routine. A couple of ideas, early ideas there, to use a standing desk like I'm using now, or walk to work. Or I could start exercising, so actually purposeful exercise. I used to do a lot of sports as a young man. I'd like to return to some sport and maybe find an opportunity to do some walking like at lunchtime. So another idea occurred to me is that there are ways of measuring your activity using an app, like a Fitbit or something, or an Apple Watch or some device like that. I thought, well, maybe a good idea to use that to track how much activity I'm using. Turns out that can also be used to monitor my consumption. So that action would actually help on both sides. My improvement project that I settle on looks like this in blue. This is basically how I'm going to go forward. This is my theory about how I'm going to end up reducing weight. We'll see how it works out. We move to quality improvement, a much bigger scope, organizational scale. Let's say reducing falls resulting in harm. This driver diagram change package was put out by the National Health Service in the UK. Itemizes 5 drivers that are based on some evidence, and then they identified 10 secondary drivers and 45 ideas and concepts underneath all of those. I don't draw that, dare draw that driver diagram here. It would be too small to read. What I want to say is that it's a starting point for the construction of your own theory about how you can reduce falls. Dr. Deming, who's guru in quality improvement, on which much of our work in quality improvement is based, used to say that experience itself teaches nothing. Without theory, experience has no meaning. And really, that's the importance of theory in a nutshell, is that it enables us to learn about our improvement theory and learn as we test change whether or not it's having the result that we expect. I like the second definition of theory from the Oxford Dictionary, an idea used to account for a situation or justify a course of action. So there are two kinds of causal theory diagrams in quality improvement. Well, there may be more, but these two I'd like to point out. One is the fishbone diagram. So a fishbone diagram, you might think on the face of it, kind of looks like a driver diagram. Fishbone diagram is actually team theories about what is causing an effect. okay? It's accounting for the present situation. They are theories. They're based on experience of the people on the team, perhaps on some data. Ideally, you would move to some data to verify those things. Driver diagram are team theories about what will result in improvement. So it's justifying the action or change. It's your theory for improvement in the future. So let's look at a driver diagram. I'll already used a couple of terms, but the improvement aim would be at the head of the diagram. You have primary drivers. This is somewhat arbitrary depending on what aim you have, but primary drivers and secondary drivers. And then change ideas are put off to the right, and the direction of cause or influence is from left to right, or rather right to left, pardon me. So the changes we're making are actually an expression of our theory, and theory is basically thinking. When you look at a driver diagram, the first two levels, the secondary and primary drivers are really your thinking. The action is out here. The change ideas that you develop are on the right-hand side. The change ideas could have to do with process, all kinds of different ideas. Typically in quality improvement, there's a bundle of changes that are required in order to make improvement. Very seldom does an improvement only require one change. So there are sort of a bundle of change ideas. When we're building our theory, the question how is helpful to build it out. We start with our aim. We ask, well, how can we accomplish our theory? Or how can we accomplish our aim? We consult the literature, we consult our own experience and some other sources in order to develop what our theory for improvement is. We can provide a rationale for change. If someone asks, why are we doing this particular change? We can say, well, we can track it through. This is our theory for why we're making this change and why this is important. So the rationale goes in the opposite direction. You need to be careful with your logic. And I'll return to the falls reduction tree diagram, or the driver diagram, just to point out. The education was situated here as a primary driver. I would suggest that education is rarely a primary driver. It's almost always a secondary driver. It's a means for enabling these other drivers to be realized. Education on its own rarely causes any quality improvement. Differentiate the driver diagram from a work breakdown structure, which is a type of project management. It's a planning tool. Well, here's a stylized work breakdown for a quality improvement project. You'll notice the driver diagram is actually one of the things that you would do in order to achieve your improvement. And you'll see over here as well, PDSA. So these things actually work together in executing and testing your change in order to make improvement. So work breakdown structure is different from the driver diagram. The driver diagram is your theory. These driver diagram and the Plan, Do, Study, Act cycle work together hand in hand, and we'll have a look at that now. You'll see that when you're testing change on a small scale and ramping up, you're actually testing your theory. You're testing that, is my theory actually holding up? We're looking for measurements as we're making these changes and whether or not the theory is being confirmed or whether or not we'd have to change our theory. Sometimes when we test change, we realize that the theory is not adequate. It's incorrect in some way, and it needs to be adjusted. So the measurement you'll need, we often talk in quality improvement about outcome and process measures. Your process measures will be very valuable when you're testing change and verifying and adjusting your theory. So plotting your changes on a run chart, annotated time series chart, in order to see that, in fact, our direction of process and change is in the direction we expect, and we're realizing our improvement. So improvement theory inputs. Where are you going to get inputs for your improvement theory? Evidence is first and foremost. By all accounts, we should use the best available evidence. And that evidence can come in all kinds of forms, not the least of which would be peer-reviewed literature and clinical guidelines. Might also be reports of quality improvement that is similar to the one we're undertaking. Experience of both the people working in the system and patients and families who are served by it and other stakeholders all feed into your improvement theory. When we have other people who have undertaken similar improvement, we can consult them and get some input from them. And also, importantly, analysis of your current state. Any process mapping, value stream mapping, data analysis that you do of your current state will feed into your theory. So how do you get started? The first thing to do would be sort of compile your inputs, reviewing the evidence, gathering experience, doing some analysis of your current state and situation to begin to formulate your theory. And then sort and organize your primary and secondary drivers. You could actually start by generating some change ideas if you want as well. But start to assemble those in some way. One way is just to start with some sticky notes and start to use a sticky note exercise to say, well, this is the primary and these two items here fit under the secondary. In some manner, start to organize them. Or you might want to use a template document to start plugging things directly in. A couple different ways to get started. So the draft is important for you to remember. Some people say, well, we've done our driver diagram now. Our driver diagram is complete. Be careful with that. Treat your driver diagram as a draft, as something that's guiding your improvement that may need to be adjusted. You'll be well served by that, and you'll be less likely to do a lot of work for no result. So I want to thank you for that. There's a couple of articles that we're pointing to help you to further your understanding and your work in quality improvement. And the best of luck.